Welcome to our very first webinar about the patient experience. We've been thinking quite a lot of how should we construct the format so that it would be interesting for you. And we also wanted to have the ability to make this interactive. So you can ask questions while the broadcast is going on. We also already received some questions from you before we started. And on top of it, today is a holiday. So for those of you who could not yet look and be here, you can later watch what we are doing right now on YouTube. And we've thought long about the format of how we really should do this. And we decided for the Google Hangout format because it can be preserved and later viewed at one's leisure. And then came the second thought, well, should we be just showing some slides? But at least whenever I'm looking at it, looking at a slideshow here and there may be getting a little long. So we decided we are going to be bringing our individual topics together in small little pieces of short little videos and then stop in between to answer your questions and also see what you've been thinking about that. So I'm going to go to do a screen share with you here and show us a little video on why you might want to actually care about this. Beginning in October 2012, the Centers for Medicare and Medicaid Services started to move away from the fee-for-service system where the more you did, the more you got paid, to a value-based purchasing program in which quality of overall outcomes counts. Now, to finance this whole program, the Centers for Medicare and Medicaid Services started to withhold now 1% of all reimbursement for inpatient services. And in 2017, this percentage will be increased to 2%. Now, you may say, well, that's not all that much, but considering that hospital margins are between 2 and, if you're lucky, 7%, a withholding of 1 to 2% by a major payer is quite a big deal. Now, participating hospitals, though, have the opportunity to recover this withholding. And if quality is better than 50% of that in other hospitals, they are not fined, but can even get a bonus, particularly if they exceed the 90th percentile of quality. Now, how is quality measured? 70% of it are hardcore data, such as management of myocardial infarction, giving antibiotics speedily, how many patients are readmitted. But 30% of it are based on patient satisfaction surveys, which have some relatively soft criteria based on which a lot depends for your institution. And furthermore, these results are being made public on the web so that everybody can see how you are performing. This was a short little introduction, and it's in a way a response to a comment someone sent in. Why can't we just throw all these satisfaction survey papers out the window? It is a reality. It has come to your hospital and you just cannot get rid of it because there is now so much money at stake. And it's not only that, it's the Centers for Medicare and Medicaid Services that got into the withholding and measuring quality in this value-based purchasing system, we are also already seeing that some of the private insurance carriers are starting to look for that. And we're going to get a little bit more into the whole issue. Well, what are actually these famous age caps on which everything now seems to be depending, at least for CMS? And here we have another one of our little videos that I'm going to show you here. Staff members' expressions of concern for comfort, how friendly they were, how attentive, and whether pain was managed in any way possible. I guess we need to start from this again here. The Centers for Medicare and Medicaid Services send out these so-called HCAPs, which is an abbreviation for Hospital Consumer Assessment of Healthcare Providers and Systems Survey. And questions address staff members' expressions of concern for comfort, how friendly they were, how attentive, and whether pain was managed in any way possible. HCAPs are typically limited to inpatients. There are now, though, a fair number of vendors that provide parallel surveys for other areas of the hospitals and outpatient treatments, and they presumably correlate with the patient's experience assessments in the HCAPs, which in turn determine the payment. And it is the surveys of these other vendors, Prescani being the most well-known among them, which are then available to hospital administrators to really drill down to individual departments, to teams, to treatments, and possibly even to professional groups and individuals. The way patients receive those are typically as a questionnaire that comes with a prepaid envelope and that then they are supposed to send back. Sometimes there are phone interviews from independent third parties, but most places still use the paper approach for that. Now, just keep in mind, you are not allowed to instruct your patients or insinuate in any way of how they should answer those surveys. If you found out, you are really fined. This was our short little introduction into how these surveys are actually working and how patients are receiving them. I do hear pretty often when going to places, well, couldn't we tell the patients that we do expect that it's like a really good rating, but you're really not allowed to do so. And again, it really is going to depend on the end whether your patient is actually going to send these surveys in at the end. And that is going to be a major factor also, interestingly enough, of how your rankings are going to be looking like. And I've seen some of you joining in here. If you have questions, again, just feel free to already type them in. And in the meantime, I'm going to go a little bit into how these rankings are actually coming together for the payments to the hospitals. And it's also going to give you already an idea of how you can influence them. Have you ever wondered how these patient satisfaction surveys work and where the rankings come from? Well, if you look at the original HCAP survey, you'll notice that the questions are pretty soft. How often did nurses treat you with courtesy and respect? How often did the doctors explain things in a way you could understand? How often was your pain well controlled? How often did the hospital staff do everything they could do to help you with your pain? And if you look at the Presgamy outpatient survey, you'll find that it's not as straightforward of how you necessarily might assess the instructions you receive or the skill of the staff or the staff's concern for your comfort. Coming to these surveys then is that patients indicate typically among 5 choices between very poor or never and very good or all the time, how they felt about the experience. These initial assessments are then translated into scores between 0 and 100. Once those scores are obtained for each question and also for a roll-up of the entire, let's say, domain, like testing treatment or personal issues, and for the entire experience, rankings are obtained, and these are done in percentiles. For example, the 90th percentile, which is considered the benchmark for the Centers for Medicare and Medicaid Services, indicates that you are better than 90% of everybody else in the country who subscribes to this service. And also keep in mind that below 50 percentile rankings, you are going to be fine. Now the problem is there is satisfaction survey fatigue among us, and very few patients send in their surveys. In a sample of over 1,400 patients per month in an institution we were able to assess, there was a 3% return rate. So let's say, if you're lucky, 10 patients send back their survey every month. And let's say 9 loved you and gave you a score of 100, and 1 of them thought you were fair and your score is 95. On this enormous hockey stick function, where the score is plotted against the percentile ranking, you see that a score of 95 is basically a 10th percentile ranking, putting you at the bottom of the heap in the country. It would look a little bit better with regard to rating, but it's only good if you don't have an ER or inpatients or, my God, even an ICU, where there are going to be more waiting times to be taken care of. So the only way to really win this game is to make sure that you have more happy patients who actually send in their surveys, and that if there's anybody who is disgruntled, that you make sure that this person is going to be satisfied. And Comfort Talk training can do just that. And particularly what can happen with unhappy patients, once they receive your attention that you learned with Comfort Talk, they're not uncommonly leave to be so happy that they're actually going to be writing a note to either your supervisor or to the hospital administration. That was a further introduction of what is happening with the rankings and the evaluation process that eventually will determine your standing towards the public, how everybody can look up on the web of how you were doing to your patients, and also how the reimbursement schedule to your hospital is going to look like. And I think the key thing to keep in mind is it has really become an arms race. And what somebody wrote to me the other day, how can we take the process back? And my response to that is, I think things will shake themselves out. And if we get beyond this phase now where everybody is doing the usual tricks to enhance the numbers, quality of the human interaction is really what is gonna make the day and gonna determine your standing in this entire process. So how can you actually affect these ratings? And our poet laureate, Maya Angelou, put it very well, that people will forget what you say and people will forget what you do, but people will not forget how you made them feel. And I've commonly seen in the modern healthcare environment that people working very hard, very quickly, they screen out everything possible they can about the patient so that the interaction with the patient is very, very short. And the patient obviously doesn't know how much work you've done for them up front. And so in this short interaction you have, if they don't have the feeling you cared, they're not going to send this survey in. You know, we all get surveys every day from the dry cleaner, from the airline, how the packaging was on the last things that got delivered to us at home. So you really have to create something memorable. And in my experience, it is if you were able to make the patient proud of how they handle the interaction, this is what is going to reflect well in the patient's experience and also in making that patient happy enough to send that survey in and get it back to you, or possibly even write a little letter and a note. Now, when we do the comfort talk training, we do exactly that. We prepare a team ideally in how to deal with stressful situations, how to overcome them, and how to help patients who are distressed to come to a state where they can be proud about themselves and move on in a positive way. Well, I'm going to show you some of the results we obtained through another screen share that I'm going to get here. And here we come into our Comfort Talk results, provided I can find them. Here they are. You probably want to know, how does Comfort Talk really work in improving patient satisfaction? Fortunately, we have hard data obtained through a hospital IT system, subjected to data analysis and stringent peer review, and published in the American Journal of Röntgenology. We had the opportunity to train the MRI team at the main hospital of the Ohio State University Hospital, and we pursued our usual training, 2 days of classroom training with intervening practice, and also some on-site coaching, and follow up on the web and web support to help the team to develop their own language styles. Training emphasized to establish instant rapport, diffuse tension, become aware of more word choices, avoid negative suggestions, and also to start using hypnodal language to manage pain and anxiety by using a short self-hypnotic relaxation script or its associated language. And all that can be done in about 90 seconds without interfering with any other work, and only if patients are very anxious or are in serious pain or claustrophobic, it may take 3 minutes or somewhat longer. On day 2 of our training, we focused on some advanced distress management skills and further elaborated on language use and also how to overcome internal and external resistance. We also had the advantage of being able to award continued education credits of 16 hours for the classroom training and then an extra 9 hours for some self-study. If you look at the results, you see the green bars encompassing 1 year prior to training, the red bars 1 year post-training in Comfort Talk, and looking at percentiles ranked among 908 other institutions in the country. Well, we didn't expect that waiting time would change, so that serves as a nice control. But you see that the factors that can be influenced by personnel really changed after the initiation of Comfort Talk. particularly how patients perceived explanations, friendliness, instructions, concern for comfort. Patients even felt that the technical skill of the team had improved, even though really neither equipment nor any algorithms of treatment and evaluation had changed. We were happy to see that the overall assessment improved from the 3rd percentile to the 53rd percentile. And keep in mind that it's below the 50th percentile where you're going to get fined. The likelihood of recommending the facility to others correlates highly with patients actually doing so, and the ability to recruit new patients and also to retain established patients. That improved from the bottom of the heap in the country from the 1st percentile, despite the hospital being a wonderful facility, to the 38th percentile. And also the perception of how well staff work together improved dramatically from the 7th to the 87th percentile. Now, we also had the opportunity to train a team at Toronto Hospital of Sick Kids, and that shows really what it's all about. This was a letter the team received after they treated a child on a very stressful day where there were extensive waits and emergencies, and then to get a letter of someone saying, great, awesome, in fact, you are to be highly recommended. And along the same lines from another patient who received this card, thank you, you make me happy. That is what Comfort Talk is really all about. I always love this big card. Thank you, you make me happy. And this is what you can achieve in the midst of stress, just with a few little extra skills. I'm pretty sure every one of you who's in the healthcare profession already knows very, very well how to communicate with patients. And it's easy to get along if you're in rapport with somebody. But if a patient is coming in a bad state, is upset for reasons you even may not have any influence about, and that's where it becomes important. Can you overcome your own inhibitions, your own concerns, your own thoughts, and can you establish rapport in that setup and bring the patient into a more resourceful state? That's what we really attempt to achieve at Comfort Talk. Please look at our website, comforttalk.com. We have a lot more on there from research that's been done, from some of the trainings we're offering, the background, some of the news where I will be live lecturing relatively shortly, or also make some comments on Facebook where you will find posts relating to healthcare professionals and those of us in the direct interface with patients and how to make their experience better. I would like to really thank you for participating today, and feel free to join the Comfort Talk community. You also can leave messages on our website, comforttalk.com, and I wish you a wonderful rest of the day and just very pleasant patient experiences. And who knows, one of these days we might be seeing in a training. Thank you very much.